Once we have secured the airway, we can move on to the final stage of induction, or rather the first stage of anesthesia maintenance, which involves initial ventilator setting. I will now shortly explain about the initial ventilator setting, more about anesthetic gases, and how they are disturbed in the human body. To demonstrate the initial ventilator setting, I will go to Drager website, where simulator is available for anesthesiologist trainee. Here is a classic control panel for the Primus device from Drager. As is often the case in anesthesiology, we have a checklist to follow before turning on our machine. First, ensure the supply of fresh gases to our system. Next, verify that the vaporizers are correctly positioned and check the respiratory system to confirm it is fully assembled, leak-proof, and all components are properly connected. Other essential checks, thought not directly related to ventilation, include ensuring the suction is operational. Once all these tasks are completed, we can start the machine. The first task is to initiate the auto test. I paused the auto test briefly so you can see the process, as it typically takes about 5 minutes as indicated here. However, as you saw, it was progressing very quickly, which is not how it usually goes. This allows us to familiarize ourselves with all the elements available for selection. After the auto test is completed, you will see the start screen. We should begin by entering the patient age. This is done by clicking the button below the square and selecting the age. Let's say our patient is 53 years old and confirm. After selecting the age, press the knob again to confirm the selection. This knob feature, which can be rotated and pressed, is quite common in all mechanical ventilation and anesthesia devices. The next parameter to set is the patient weight. For simplicity, let's say our patient weight is exactly 70 kg. The next parameter to set is the pre-oxygenation flow. We aim for a high fresh gas flow to ensure an open or semi-open system. Let's initially set this to 9 liters per minute and confirm by pressing the button. Next, we increase the oxygen concentration to 100% and confirm with the button. This sets the fresh gas flow. Below, you can see several additional buttons with descriptions. In this section, we can see the composition of our gas mixture. If we select air, it means we will be mixing oxygen with atmospheric air, which contains 20% of oxygen and 78 nitrogen. If we select this option, our 100% oxygen will mix with 100% nitrous oxide. In this section, ventilation modes are displayed. Several modes are available on this device, more than on ours. Today we will focus on two: manual or spontaneous mode, which I will now set. After selecting the mode, you can see the flashing light. Confirming the mode takes us to the standard mechanical ventilation screen, which you now see. This screen is divided into several sections. Here we have information about the gas mixture, including the concentration of oxygen, nitrous oxide, or in this case, isofluran, in inhaled and exhaled air. The machine also calculates the Mach. An alarm has just sounded, indicating insufficient minute ventilation. Unfortunately, there is no bug here that I could squeeze, meaning the patient is not breathing. The machine starts to alarm. At this stage, we need to work with the bug. Since this is not possible in the simulator, we will move to the second mode I want you to be familiar with. This is the volume controlled mode. I selected it and confirmed by pressing the knob. I hope you notice the appearance of the curves. And this first curve is capnography, showing exhaled carbon dioxide. The next curve shows the pressure curve. I hope it is clear that in mechanical ventilation the pressure will always be positive. The last graph shows the flow curve. We will not go into detail about them now. The most important parameter I want to focus on is minute ventilation. We control ventilation based on exhaled carbon dioxide, but we need to understand some basics. Our anesthesia machine, as you can see, knows this basic very well. It has set the standard tidal volume at 490 milliliters. Typically, one breath should have a volume of 7 milliliters per kilogram of patient body weight. Therefore, the machine has set the standard rate between 12 to 16 breaths per minute. I hope it is easy for you to calculate the minute volume in this case, as it is 490 times 13. During the subsequent stage of anesthesia, we will monitor carbon dioxide and ventilation and adjust our minute ventilation accordingly. Along with setting the minute ventilation, we will reduce the fresh gas flow. I have already done this, reducing the fresh gas flow to 1 liter per minute and 50% oxygen concentration. Other mechanical ventilation parameters and modes will be discussed in a separate seminar. PIP plays a special role. I hope you have noted this and encourage you to learn what positive and expiratory pressure is and its role in furthering your knowledge. Once we have set satisfactory ventilation parameters, we will also want to maintain anesthesia. Here are all the available options, but the most commonly used today are sevofluran, desfluran, nitrous oxide, and occasionally isofluran. Halotan, enfluran, cyclopropan, ether, and chloroform are now of historical significance. Xenon is very expensive and has certain limitations, though it might soon see a renaissance with methoxyfluran. When discussing anesthetic gases, it is essential to understand the concept of MAC. MAC is minimum alveolar concentration that will prevent movement in response to pain stimulus in 50% of patients. MAC is therefore a measure of anesthetic potency or the minimum effective dose. The lower the MAC, the less anesthetic is needed to achieve adequate anesthesia. The most important factors modifying MAC are primarily age, but also body temperature, pregnancy, and the use of opioids or other sedative agents. MAC is expressed as a percentage. As you can see, nitrous oxide has MAC of 104. This means It should not be used as a sole anesthetic, except in exceptional conditions at elevated atmospheric pressure, where we could theoretically achieve MAC of 104%. But this is not done in practice. Nitrous oxide is always used with other anesthetics for many reasons. One of these properties is analgesic effect. Additionally, its use increases the risk of postoperative nausea and vomiting. Another significant aspect, which is somewhat advantageous, is its high contractility, but it also brings certain limitations. Nitrous oxide is very poorly soluble in blood. This means that if we manage to dissolve it by applying the right concentration, it will quickly escape if it finds any air-filled space, such as in cases of obstruction, air embolism, tension pneumothorax, or procedures involving the tympanic cavity, potentially significantly increase the volume of these spaces, which is potentially very dangerous. Another crucial aspect of its poor solubility in blood is that if we stop administering nitrous oxide through our anesthesia machine, it will diffuse so quickly from the blood to the alveoli that it can cause so-called diffusion hypoxia. It will displace the oxygen that should be entering the bloodstream, causing hypoxia, even if the patient is breathing an oxygen 100% of oxygen mixture. Therefore, when waking patients who have received nitrous oxide, it is always essential to use 100% of oxygen. During the use of this gas, we have to be aware of serious complication known as bone marrow aplasia, which result from inactivation of vitamin B12. Another anesthetic gas, often considered the king of operation room, is sevoflurane. While nitrous oxide is delivered directly, usually through fresh gas outlets, sevoflurane, desflurane, and other anesthetics are delivered through specific vaporizers, like the one shown here. Each anesthetic is designed with a specific color. For sevoflurane, the color is yellow. It does not irritate the respiratory tract. While all anesthetic gases smell unpleasant, sevoflurane's smell is tolerable. Because of this, it is often used for inhalation induction in children. Additionally, in case of bronchospasm or other air spasms, it can help relax these airways. Sevoflurane can also reduce intracranial pressure to a certain extent, making it favored in neurosurgery. It ensures relatively good hemodynamic stability. Its MAC is 2.05%. It is metabolized by 3 to 5%. Unfortunately, it can release toxic fluorides. These fluorides are nephrotoxic. Example is compound A. Compound A is another substance resulting from reaction with the system related to sevoflurane. When sevoflurane reacts with the limit in the carbon dioxide absorber, it produces compound A, which is nephrotoxic. Another currently popular gas is desflurane. A primary difference is that it irritates the respiratory tract, so it is not used for induction. It is only used for maintaining anesthesia, making it available only in mixed anesthesia. It is the least context sensitive and highly controllable. These properties are due to its low solubility. Consequently, small increase in its concentration lead to significant rise in its partial pressure. This partial pressure is the driving force for delivering the gas to other tissues. Therefore, saturated blood will readily deliver desflurane to the brain, where it acts. Desflurane, however, is weaker than sevoflurane with MAC of 6 to 7%. It is favored in bariatric surgery because it does not dissolve in fats. Unfortunately, another limitation is its high vapor pressure. Due to this, the fluorine vaporizer is unique, requiring electricity and maintaining a temperature higher than ambient. The manufacturer decides to raise the temperature in the vaporizer because the fluorine boils at room temperature. This means it is a gas at room temperature or on the verge of boiling, making it very hard to control. Unlike sevoflurane, we are not dealing with vapor concentration, but with boiling point. This reduces its controllability. Therefore, to move away from the boiling point, the vaporizer is highly heated, improve control over the gas. Xenon. Xenon is fascinating gas. It could be considered an ideal anesthetic, though not very potent. Its Mach is 71, but it can be safely used in an oxygen mixture. It is very stable, provides neuroprotection, and has anti-emetic properties. However, it has significant drawbacks. Producing it is very expensive because it can only be extracted from noble gas in the atmosphere. It requires complex closed system due to how easily it escapes standard system. It is one of the anesthetic closest to the ideal. One major advantage is that it is the only gas that do not cause malignant hypothermia. Theoretically, the use of anesthetic gases, starting with chloroform, has been associated with specific stage during the induction of anesthesia. The first stage shows pupil dilatation with light response, irregular breathing, irregular pulse, and initially stable blood pressure. Thanks to multimodal anesthesia combining different agents, now we manage to avoid the excitement stage. Therefore, we often opt for intravenous induction. At this stage, significant agitation can occur, both in the cardiovascular system and psychomotor activity, posing a risk to the patient. We aim to avoid this stage during induction. The appropriate stage for performing surgery is stage 3, where the pupils are moderately dilated. The patient is not paralyzed, would breathe rapidly and shallowly but regularly. The blood flow remains unaffected. Using volatile anesthetic can lead to overdose, potentially causing cardiac arrest. The first alarming sign is significant pupil dilatation. Stage presented in the table are no longer used, replaced by concept of gas saturation. I will explain the gas flow and the phases of saturation and equilibrium. To demonstrate the process of gas saturation, I will use Gasman program. This excellent program illustrates various distribution spaces. Here we see our ventilator or respiratory system along with the anesthesia machine. Here we can see the mask applied to the patient face. Next is the alveolar volume, essentially our lungs. In these two narrow columns, we will find arterial and venous blood. There will be fast and slow compartments, in this case mainly muscles as hydrophilic and fat as lipophilic. We can also see some parameters at the bottom that will influence the saturation and certain time frame. I will leave the minus ventilation and cardiac output unchanged. I want to demonstrate the fresh gas flow. This is where the vaporizer for the selected gas is located. This time it is sevofluran. After clicking the play button and immediately stopping it, we see that about 4 seconds have passed, and nothing has happened in the system yet. I will wait a little longer. As we can see, the system has been quickly saturated with sevofluran. Even though the alveolar concentration has started to rise, as you can see, nothing has happened yet in the brain tissue. This is within the first 9 seconds of the saturation phase. I'm about to continue the sevofluran saturation phase. We can observe the columns gradually rise. I'm stopping here for a moment because I have just reached the Mach. That means in the alveolar exhaled air, I have reached a concentration that should cause a lack of response to painful stimuli in 50% of patients. However, know that the concentration in the brain is still too low. So far, 1 minute and about 30 seconds of anesthesia have passed. I cannot start the surgical procedure right now because I'm not sure if my patient is unconscious due to lack of correct sevofluran concentration in brain tissue. Therefore, I need to wait longer. I want to point out that with these settings, high fresh gas flow and high vaporizer setting, the value which I can measure in exhaled gas is higher than Mach, even though the cerebral Mach is still too low. Even after 4 minutes, I still have not achieved the appropriate concentration in the brain. It is generally accepted that with a properly conducted saturation phase, 5 minutes should be suffice. After this time, the surgery can begin. I also want to draw your attention to the fact that while the other compartments were not significant during the saturation phase, they will become important shortly. As you can see, they are gradually starting to saturate. At this moment, because anesthesia is quite expensive, I need to reduce the fresh gas flow. I should have done this sooner. Let's say I won't reduce it as much as I could, but I will reduce it to 3 liters. Notice that the amount of drug I will be delivering has significantly decreased, even though I am still delivering 3.7% sevofluran in the fresh gas flow. The fresh gas flow is now 3 liters, so I am delivering about 3 times less sevofluran to the system. Know that I can observe a balance, but this balance will be temporary because the human body will continue to saturate. Particularly the fatty tissue here will be slow and muscle tissue will be quick. After ensuring the appropriate depth of sleep, this anesthesia must be nighttime. It can be done by sevofluran or other anesthetic gases, but sometimes we also doing it with a continuous infusion of anesthetic agents, and sometimes in short procedures we use fractionated maintenance doses, especially with propofol. However, there is generally no such thing as a drug to wake the patient. There are, however, 4 very important antidotes in anesthesia. They are flumazenil for benzodiazepine, neostigmine for the non-depolarizating muscular relaxant, sagamadex mainly for rocuronium, and naloxone as an antidote for opioids. However, I advise caution with naloxone as there are reasons why we are administered the opioids in large doses, and reversing them can cause significant pain and discomfort for our patient. Sometimes it is just better to wait until their action is over. Sometimes it is about patience. Thank you for your attention.